Okay, so I'll be talking to you about some pearls I guess I've come up with over the years for diagnosing dementia. This is a picture actually when I was at the VA, and it's kind of my view now back at Harborview on a good day seeing Mount Rainier. So this is one of the slides I came up with a long time ago, but it still really applies. And I like to think about cognitive impairment being a geriatric syndrome. And I think this really applies both for a patient that you're seeing for the first time that has new onset cognitive impairment, or that you're evaluating for the first time, or a patient that you know already has dementia but is getting worse. You know, a patient with stable Alzheimer's, but all of a sudden is presenting with new cognitive impairment or new worsening. So of course you have your neurologic diseases like Alzheimer's, TBI, Lewy body, stroke. But all these other factors can influence their cognition, whether their medical diseases are out of whack, diabetes, thyroid disease, sleep apnea, whether their medications are out of whack, either drugs we're giving them or drugs they're giving themselves, psychiatric conditions, and of course, psychosocial supports or lack thereof. These can all affect somebody's functional status, cognitive status. So I'm going to start out by I have a couple of slides talking about normal aging, mild cognitive impairment, and dementia more broadly. And then I'll narrow in on kind of the top 3 diagnoses that we see over and over and over in memory clinic, and then a little bit about how we work those up. So of course, in dementia clinic, on the bus, like literally yesterday, my cousin texted me like, when do you know if it's dementia or when is it normal aging? And I think this comes up a lot, and it's such a good question, and it's going to be a complicated question always. But this is a slide I borrowed from the Alzheimer's Association, and I think it's really helpful to have this kind of as a framework. So to have like a framework for normal aging, a framework for hardcore dementia, and then you can kind of, you know, work those edge cases in between. So what's normal aging? There are changes in our brains and in other organ systems, of course, that do lead us to have some cognitive decline as we age. Normal aging is making a bad decision once in a while. Short-term forgetfulness, losing things from time to time. Really, the bottom line is some short-term memory loss and more time and energy needed to encode new information. There's a lot more to this slide, but at least this is kind of like the highlights. Whereas dementia is really poor judgment and decision making. You really can't manage a budget. It's not that just you forgot to pay your power bill once. It's you can't even manage it at all. You lose track of the season or year, and not just January, but like all year. It's really hard to have a conversation. You forget what you were going to say and then you just veer off. You misplace things and you don't even remember what you were looking for. Very difficult to encode new information. And this is kind of the paradigm of Alzheimer's, not necessarily all dementias. But I like this slide because on the one hand, it can kind of be reassuring to your worried well, and it can also be, no, hey, this is something going on that's wrong and needs more workup, to someone that is having more significant symptoms. And then of course, mild cognitive impairment is like in the middle. So this is a slide from one of the HRSA modules on MCI, but basically mild cognitive impairment, or MCI, is problems with memory, language, judgment, or thinking, problems that are greater than expected for age, but not bad enough to be dementia. So of course, it's literally like in the middle. They can still carry out everyday activities, depending on what those everyday activities are. And not all MCI will progress to dementia. So that's good to know. I tell a lot of patients, hey, that we don't know for sure what this prognosis is. And some of the treatable predictors or risk factors associated with MCI, according to this list, are a lot of things that you all see in clinic all the time. So diabetes, prediabetes, or the metabolic syndrome, just bad hypertension, hyperlipidemia, low folate. I'd probably add low B12 in there as well, chronic alcohol abuse, renal failure, depression. And then I added medications to that list, being on a lot of sedating medications. When does it become dementia? You have cognitive impairment, but you've defined by history and some kind of assessment like a MoCA or a 3-MSE or MMSE or some kind of testing. It's a decline from their previous level of function. It's interfering with their ability to function either at work or their hobbies or activities. You've excluded delirium or major psychiatric disorders, and you've distinguished it from normal aging. So these are kind of the nuts and bolts of when you have dementia or a neurodegenerative disease. Usually I torture the residents and I make people guess what's number 1, what's number 2, what's number 3, but I'll just let you all see the slide. So the number 1 cause of dementia in older adults is Alzheimer's. So if you see a patient and you're worried about dementia and they're older, it's probably Alzheimer's. If you're not sure if it's dementia, it's probably Alzheimer's. If you know, it's like a mantra in my clinic. It's probably Alzheimer's. But there are other kinds, of course. Lewy body and vascular dementia are also pretty common. The other thing that's really common is mixed etiologies. Particularly the older you get, the more pathologies you start building up in your brain. And it's been my experience in memory clinic that the diagnosis really does help you change your management and your prognosis. You know, someone with mild vascular dementia may not progress as much, might stay stable for years. I've had some patients that I diagnosed with vascular dementia like 6 years ago, and they're still kind of the same. So, I mean, you know, the diagnosis really can make a difference to what they're going to look like down the road. So I put this slide in. It's a little old now, but it still kind of applies. What this is showing you is the course of Alzheimer's disease in terms of the markers and then the symptoms. So what we're looking at here is the red line is amyloid. And that starts building up decades before you get symptoms. So the amyloid builds up and plateaus out, and then you start getting intracellular tau. Finally, you start getting MRI changes or brain structure, memory changes, and then this is clinical function. So by the time the receptionist can diagnose Alzheimer's, okay, these biomarkers have been increasing for decades. And this paradigm is true for most neurodegenerative diseases, Lewy body, et cetera. The biomarkers have likely changed the brain structure years ago. The other thing that I've noticed being in clinic, and maybe this is a little bit because I'm at a referring center and sometimes we get the odd cases, but things don't always match up. But often they do. You learn what the cases are supposed to be like and the symptoms in the textbook, or what the pathologic diagnosis should be if they go to autopsy. And then what the clinical diagnosis is and what they're supposed to present with. And they don't always completely line up, and people are complicated and they have things like comorbidities and things like that. So I like to make diagnoses and hold on to them lightly. And it's okay to be wrong. It's okay to add. It's okay to be unsure. And what I tell my families is, you know, I'm pretty sure you have something wrong with your brain. You know, here's your MRI. It doesn't look normal. You've been having these symptoms for a long time. And I'm quite concerned you have a chronic disease that's not going to have a cure. But we're still trying to figure out what kind it is. In the meantime, here's these 5 things we can do to help your family, you know, a pill box, caregiver support, et cetera, et cetera. And so it's okay to be wrong. It's okay to not exactly know the diagnosis. Sometimes you don't. So to diagnose Alzheimer's, the pathology is plaques and tangles. It's very rare under age 60 unless you have a very strong family history. These people have insidious gradual onset of amnestic memory loss, so forgetting things, repeating questions over and over. Some language predominant too, where they really have trouble speaking or forgetting a word. The MRI shows medial temporal lobe atrophy, and the treatment is Alzheimer's meds and SSRIs predominantly. Here's an asterisk about the insidious gradual onset. I mean, I don't know how many of you have, you know, seen a new patient for memory loss and you say, like, how long has this been going on? And they say, oh, about a year. and their MoCA is like 10. You think, oh, were they 30 out of 30 a year ago? Like, that's really bad, rapidly progressive. But you know, you sit there in the room and the wife says, oh, it's been going on a year. And the daughter says, Mom, remember, no, 4 years ago. And they have this big, long argument about how long ago it started. That is so classic for Alzheimer's, right? Because it's insidious and it's gradual and it's hard to say. And the other thing that you'll sometimes see is like an abrupt onset of dementia when someone moves or has surgery or has delirium and has a new baseline. I would say question how rapid it really is. Ask, well, how really were they a year ago or 2 years ago? And dig through the chart. And they had an MRI 2 years ago for memory loss. Not, you know, so, okay. So question, and assume that it's not, that it's longer. But if you really honestly do have someone that has a rapidly progressive dementia that's really only a year or two, like they really were like teaching at Cambridge a year ago and now they're super impaired, that does warrant a much more rapid and workup and things like that. But 9 times out of 10 or more, when it's rapidly progressive, it's not. So we can talk more about that in the questions, but insidious gradual onset is like that slide. It takes a long time. Okay, so Alzheimer's disease, this is a coronal section of the hippocampus. You can see a normal seahorse here in the inferior lateral ventricle. I guess it looks like a seahorse to somebody. Alzheimer's brain, you can just see a lot of generalized atrophy and then really hippocampal atrophy, left greater than right here. And that's classic for Alzheimer's. Vascular dementia is interesting. Of course, you can get to vascular dementia in a couple ways. One is you have a stroke and then the next day you have cognitive impairment that stays. That's not a diagnostic dilemma. That's not hard to diagnose. What I see a lot more common in my clinic is just kind of generalized, maybe stepwise, but more gradual onset of executive dysfunction and maybe some walking deficits, but they're just kind of non-specific neurologic deficits. And they look more like Alzheimer's. And here's their MRI. There's just tons of white matter disease. It's more than just some ditzels, and maybe they have some atrophy. So if you get a report that says chronic white matter hyperintensities, go ahead and look at it and see how bad it is. If there's a lot, consider diagnosing vascular dementia. If there's just a couple ditzels, consider not. And I know that's not very, that's kind of vague, but after you look at a few of these folks, you know, you might get a feel for that. And there are research criteria for these kind of things, but I can just tell you in clinical practice, it's really about kind of just seeing these folks over time, kind of, you know, seeing their clinical scenario. And the times that I diagnose just pure vascular dementia is if they have had a known stroke or they're younger with a lot of this stuff. Most folks get diagnosed with mixed. They have AD plus vascular. And then the treatment's kind of the same anyway. Lewy body or Parkinson's disease dementia, the core features are fluctuating cognition, recurrent well-formed visual hallucinations, typically of people or animals. They can be quite vivid. Like they can live in a room with a football team and they can be coaching them and stuff. It's very fascinating. REM sleep behavior disorder, so acting out dreams, sleepwalking, sleep talking. Parkinsonism features, if they have them in an onset a year of cognition, it's called Lewy body. If they have Parkinson's disease for a long time and then they develop cognitive impairment, we do call that PDD. Although I'm kind of thinking, what if they just have Alzheimer's too? But luckily they're kind of treated the same. So yeah. They may respond better to acetylcholinesterase inhibitors. There's something about losing the basal ganglia and the types of neurons they're losing. They lose choline neurons too. And the hallucinations actually can respond really well to donepezil. And they may be more impaired on attention, executive function, and visuospatial. And then frontotemporal dementia, you know, I mean, it certainly is something that geriatricians see. but if you're seeing like a more younger practice, like if you're seeing 60-year-olds, it is as common as Alzheimer's in younger patients. So in your 60-year-olds, and they have a new onset psych disorder or new onset aphasia, and they don't have a stroke. So of course, aphasia, the first thing you do is rule out a stroke. So look for that vascular change. But if they have aphasia or behavioral change, this is something you want to worry about. And it's much more likely to be familial or genetic. So all of our FTD cases get referred to our geneticist. They don't always see her, but they at least get offered her. And then here's the criteria for behavioral variant FTD. Early behavioral disinhibition, so socially inappropriate behavior, early apathy, loss of empathy early on. You see that in later dementias when people are just really impaired, but this is early in FTD. Early stereotyped behavior like pacing and wandering early. Diet change, and it can be subtle, like they have more, they want to eat more carbs, and it can be more dramatic, like they're eating out of the garbage. And the neuropsych profile is, their memory is actually pretty good. I think the thing is just to be skeptical of a new onset, like dramatic mood disorder in an older adult, like bipolar or schizoaffective. I would just make sure they get an MRI and watch carefully, because a schizoaffective disorder is treated very differently than FTD. FTD is not going to respond to the antipsychotics as well. So frontotemporal dementia is what it says it is. It's atrophy in the frontotemporal lobes. And this is sort of cheating because it's from the internet. In clinical practice, I don't always see them this dramatic, but I have occasionally seen them this dramatic. I do with PET scans, and that leads me into some of the more fancy workup. What do you do when you have a patient that you think has dementia? First, I would say, and I guess I should have made a slide about this, but
I think we lost your audio, Angela.
Angela, I think you're muted.
It doesn't look like you're muted through a Zoom. Do you have a mute on that headset, maybe? A mute button?
do you want
There we go. You're back.
We can hear you.
I guess my audio was lost there for a minute.
Yep. We have you now.
Hello?
Yep, we can hear you.
Oh boy, I can see Kate moving her lips, but I can't hear her. But I guess you can hear me. Okay, well, questions will be difficult, but I guess I will keep talking, and I guess someone can tell me if they can no longer hear me, but it's because I cannot hear you at all. So the history is the most important piece. If no collateral, so if someone comes alone, that's always hard because they can just say, I can say, oh, are you paying your bills okay? And they can go, yeah. Like, oh, okay. So it's always hard. But, you know, dig through PCP notes. Are they missing appointments? Are they taking their meds okay? Like, those are some of the things you might be able to get from the chart. Sometimes you just don't get collateral information. Get what you can. Medication lists are really important. What are they taking? What are they taking illicitly, potentially marijuana? I mean, it's legal, but, you know, make sure you know all the things they're putting in their body. I've been burned by this, like assuming alcohol use was minor when it was more heavy. So really trying to get a sense of what the med list and substance use is. Testing, we do MOCAs, Montreal Cognitive Assessments at our clinic. It is required now that you do an online training, and it is, I think, a one-time fee. I don't think it's going to be required to pay that multiple times. I think it was like $100, which it is a steep fee for some. I guess it was, I mean, my stethoscope was more expensive than that. So it's sort of like one of those, you know, if a clinic can have someone pay for it, and then you're done forever. It is very well validated, and it is available in a lot of languages. And then trainees are covered. Trainees do not need to do the training as long as they're covered by an attending. So Jesse's fine for today. If he does a MOCA, I can be his, I can sign his note. He's in clinic with me today. But if it is a steep fee or you don't want to do that training, there are other tests that you can do. Pick one that you're familiar with and just get good at it. So testing, history, and then labs. I usually like to see a TSH and B12 for reversible causes. And then a Chem7 and LFTs, both for diagnosis. And if I'm going to prescribe medication, I want to make sure their liver and kidney function is okay before I prescribe mood stabilizers or donepezil or stuff like that. So it's always good to have those on file. And then for risk factors, you might get an HIV or RPR. And then, more stuff if they're young, rapid onset, atypical. Then I put kind of the fancy stuff. I mean, this is stuff we get a lot in our clinic because we're the fancy workup clinic. Imaging. I mean, everyone gets an MRI. I'm not going to lie. It's such a good picture of the brain. You rule out surprises. You really get good pictures of the back of the brain, the cerebellum, the deep structures of the brain to rule out some of the more oddball stuff. We rarely get a CT. CTs just aren't that helpful. I mean, if they had one because they bonked their head in the ER, I mean, it's helpful to look at it. And if they're 85 years old and it's probably Alzheimer's and their CT shows atrophy, you probably don't need to get an MRI. There are times where we don't get an MRI, if the diagnosis is really not in question. Special imaging, we do get a lot here in our clinic. So if you're trying to figure out what the diagnosis is, and we're talking younger people, and we're not sure what the diagnosis is. EEG, if there's spells, lumbar puncture. So a word about lumbar puncture is really, unfortunately, there's no biomarkers yet for frontotemporal or Lewy body. So you can really only use a lumbar puncture to rule out cancer and that kind of stuff, or you can rule in or out Alzheimer's. But if you're debating between Alzheimer's or if you're debating between like FTD and Lewy body, a lumbar puncture is not going to help you. Neuropsych or speech therapy testing, I think those are where a lot of the help is at, because not only does it give you a lot of strengths, weaknesses, profiles, but you can also use with therapy. And I wish in a longer talk I could really go into detail, but neuropsych or speech cog testing can help you distinguish types of cases, capacity evals, and you can use them for therapy as well. Occupational therapy can also help you with ADLs. So can they cook an egg in their kitchen safely? Do they know how to do the steps? I've used that a lot for patients who English is their second language, or English is their second language, and language skills are limited. So a lot of our neuropsych or speech therapy tests rely on you to be literate in something. So occupational therapy can be helpful for that. I think we're running short on time, so I'm going to skip these slides and we can come back to them if we have time. But really quick, when do we stop medications? Always, it's okay. It's always okay to have the conversation. Hey, is it time to stop this medication? And you can always restart it. For Alzheimer's meds, there's no guidelines. I stop when there's side effects, when it's clear they aren't working, when patients are having trouble swallowing. And you all know there's a whole bunch of guidelines. I think there was just an NPR segment literally about aspirin. You can stop it, it's fine. Give them permission to stop meds. It's lovely. Families will love you for that. It's okay. So pearls, last slide. Cognitive impairment is a geriatric syndrome. Keep dementia on your radar in older adults. I think CTs are unhelpful. If they happen to have one already, sure to look at it, but okay to diagnose over time. History is often the most important piece. And it's definitely okay to refer for early onset, rapid onset, or tough cases. Neurologists or our clinic is happy to see those complicated folks to help you with the diagnosis. And